Hello everyone, my name is Pooja Uppalapati, and this is a presentation on torch infections. The goals and objectives of this presentation are to describe the various infectious organisms that can cross the placenta and infect the fetus, to outline the maternal presentation of the illness, to review the effects on the fetus and the resulting neonate, and to briefly review treatment and prevention of torch infections. TORCH is an acronym that stands for the variety of most commonly seen and tested congenital infections. The first infection, T, is going to be TOXOPLASMA gondii. It's an intracellular parasite. Tissue cysts or oocysts are the main form and can be found in undercooked meat and cat feces or contaminated food or soil. This is a commonly tested boards question. The image below are tachyzoites. The tachyzoites can replicate rapidly in infected cells, causing necrosis. Necrosis will eventually lead to tissue calcification. Congenital infection through transplacental transmission can happen after infection during pregnancy or reactivation of dormant toxoplasmosis in pregnancy. Toxoplasma can affect the fetus in a variety of ways. Usually, they are asymptomatic at birth. The classic triad that you see with congenital toxoplasmosis is chorioretinitis, hydrocephalus, and intracranial calcifications. The images on your right show hydrocephalus, increased fluid buildup in the spaces in the brain, and chorioretinitis, inflammation of the choroid and retina. Intracranial calcifications would also be seen on this scan as bright white spots. Most commonly, the symptoms of congenital toxoplasmosis are anemia, seizures, jaundice, splenomegaly, and hepatomegaly, which is enlargement of the spleen and liver, thrombocytopenia, a drop in platelets, and motor and cerebellar dysfunction. Microcephaly, which is a small head, and intellectual disability as well as sensorineural hearing loss are also commonly seen. You want to test the mother for toxoplasmosis and also the child. You can screen for the IgG or IgM antibodies, as well as look for the parasite using PCR. If the mother is diagnosed before 18 weeks, you can treat the mother with spiramycin. If there is a confirmed transmission to the fetus or the newborn infant, regardless of symptoms at birth, you would want to treat the newborn with pyrimethamine and sulfadiazine, as well as folic acid for 12 months. Folic acid is very important for development and growth. You'll want to repeat testing after therapy is given and monitor with neuroauditory and ophthalmic exams, as these are very common manifestations of congenital toxoplasmosis. The image on the right is a schematic of the life cycle of the Toxoplasma gondii and how it is transmitted. The next T is Treponema pallidum, also commonly known as syphilis. Syphilis is a sexually transmitted infection caused by the spirochete Treponema pallidum, which leads to the disease. Usually, it will present in the mother in a variety of stages. The first stage is usually a painless chancre. Then, there will be a rash that is often seen on the palms and soles in the second stage. The third stage is medullator and will appear as granulomas affecting bones and joints. Syphilis is one of the few fully treatable infections in this list, so congenital infection is truly preventable. The highest risk of transmission to the child is seen with poor antenatal care, high titers during pregnancy, early stage of syphilis during pregnancy, and early stage of pregnancy, as well as late treatment of the infection, meaning it was caught too close to delivery. You can see in this chart below that there are a variety of symptoms from congenital syphilis. It can affect the reticuloendothelial system, mucocutaneous, skeletal, neurologic, and ocular. It can cause anemia and thrombocytopenia like many of the other torch infections. It can also cause a rash. However, this rash is very particular as it's on the palms and soles. Rhinitis in the newborn, also known as snuffles, is very commonly seen and can be seen in the picture on the right. Snuffles contain high loads of the bacteria Treponema pallidum, and are therefore infectious and contagious. Skeletal manifestations of congenital syphilis are also very common. Symmetric long bone lesions can be seen. Something called saber shins is a buzzword for syphilis. You can also see other bone abnormalities such as a saddle nose and dactylitis. Neurological manifestations can include meningitis, cranial nerve deafness, and there are also ocular manifestations, chorioretinitis, and glaucoma. The second image on your right represents Hutchinson teeth, which are very characteristic of syphilis. The spirochetes can cross the placenta and cause congestion, restricting blood flow to the fetus. The infection causes an inflammatory response that does not affect organ development, but it can affect organ function. That's why you will not see organ development issues in congenital syphilis. To test and treat, you will want to screen all pregnant women at the first prenatal visit and repeat at the time of delivery. You will want to treat the mother with IM benzathine penicillin. And if they are allergic, you must sensitize them. This is the only medication that will work, and it is imperative that they are treated before delivery. If there is a concern for congenital syphilis, you will want to test the infant with VDRL, RPR, or FTA-ABS tests. The next organism is parvovirus B19, also known as Fifth's disease. This comes under the O category, or other, in torch infections. Parvovirus is a single-stranded DNA that's transmitted via respiratory droplets or blood. Those with parvovirus infection can present with a distinct slapped cheek facial rash and a macular rash that starts on the trunk and spreads outwards. There is usually a fever 1 week prior to this rash. Occupational exposure, either in a healthcare setting or even in daycare setting, can increase the risk of seroconversion, which means that the person who's infected can form antibodies. The vertical transmission risk is relatively high, around 35%. This usually happens 1 to 3 weeks after maternal infection, and it is via transplacental transmission. Parvovirus attacks erythroid progenitor cells and causes both direct toxic cell injury and the induction of apoptosis. This often leads to anemia and myocarditis. If the fetus is affected, the infection may spontaneously resolve. However, common sequelae of fetal parvovirus are severe anemia, non-immune hydrops fetalis caused by heart failure, thrombocytopenia, maternal mirror syndrome, meningoencephalitis, or fetal demise. The picture on the right shows hydrops fetalis. It is a type of heart failure where fluid builds up in the fetus, as you can see from the ascites or increased fluid in the abdomen and skin edema. To test and treat for parvovirus, you will want to test for IgM antibodies in the mother, which are detectable 7 to 10 days after infection and peak around 2 weeks. PCR is a more sensitive test. Amniotic fluid can also be tested for fetal infection. If there is a concern of fetal transmission, you will want to monitor with ultrasounds for 12 to 20 weeks after the possible exposure. Fetal treatment is to manage the anemia and fetal hydrops with in utero fetal transfusions. Persistent congenital infection with parvovirus B19 can lead to red cell aplasia, and most of the care for these infants is supportive only. The next infectious organism is varicella zoster, also known as chickenpox. Varicella is a herpes virus and is often characterized by a pruritic, blistering rash that is often seen in different stages of blistering. After the primary infection with the rash, the virus remains dormant in the dorsal root ganglion, which is why it can cause sensory symptoms later in life. Shingles is a later manifestation of chickenpox and can present during pregnancy or any other form of immune suppression or stress. Chickenpox can be transmitted through reactivation or active infection. You will want to diagnose varicella by the appearance of a rash, a zinc smear from a blister, direct fluorescent antibody, or through looking at IgM and IgG. Congenital varicella syndrome often comprises a variety of symptoms. You will see underdeveloped toes or fingers, anal and bladder malformations, encephalitis, microcephaly, and aplasia, microphthalmia, cataracts, and chorioretinitis, spinal cord damage, Horner syndrome, cicatricial skin lesions, hypopigmentation, and motor and sensory deficits. Encephalitis would be an inflammation in the brain. Microphthalmia is when eyes are smaller than normal. And Horner syndrome, which is often seen when the classic triad of miosis, a constricted pupil, ptosis, a drooping of the eyelid, and sweating of one side of the face. The skin findings with congenital varicella often appear like scars. The image on your right is what the underdevelopment of the limbs can look like in congenital varicella syndrome. The likelihood of transmission to the fetus is higher if the mother is infected in the first 2 trimesters. Another time where there is a high likelihood of transmission to the fetus is when the mother is infected close to delivery. This will instead be called neonatal varicella. This also carries a 30% mortality. The antibodies, as well as an active infection, can be transferred through the placenta. Maternal infection is associated with preterm delivery, but not fetal demise. If you are concerned about congenital varicella, ultrasounds are often done to look for intrauterine growth restriction, microcephaly, ventriculomegaly, which is an enlargement of the ventricles, and the presence of echogenic foci in the fetal liver, as well as circular scarring and deformities of the limbs, as we mentioned earlier. PCR of the amniotic fluid can be done to test for varicella zoster DNA. If the newborn is born with congenital varicella syndrome, you can treat with antiviral therapy as well as varicella immunoglobulins. You will also want to treat pregnant women with immunoglobulins if there is a high concern of transmission. However, you would not want to give the chickenpox vaccine to a pregnant woman. The next organism is rubella, also known as German measles. This is now the R portion of TORCH. Rubella is a single-stranded positive sense RNA virus that is transmitted through aerosolized particles. It presents with a mild flu-like illness with a rash that starts on the face and spreads towards the hands and feet and fades in about 3 days. The rash is less erythematous than measles, and it's often accompanied by swollen lymph nodes. There are 2 points where there is a highest risk of congenital infection. The first is in the first trimester of pregnancy, and again at term. Rubella causes progressive necrotizing vasculitis and a focal inflammatory response. Congenital rubella syndrome presents with an infant that is often small for its age, deafness, cataracts, again, microphthalmia, which is common with other infections, corneal opacities, and glaucoma. There are many cardiac defects, most notably PDA, pulmonary artery stenosis, and coarctation of the aorta. PDA is patent ductus arteriosus. Blueberry muffin rash is also seen in rubella. However, this is not specific for rubella, as other TORCH infections may also cause this rash. Hepatosplenomegaly is also seen. Later manifestations of congenital rubella syndrome can also be hypertension and diabetes in the young child. To test and treat for rubella, women of childbearing age should be tested to see if they are immune to rubella from previous vaccinations. If not, they should have 1 dose of the live MMR vaccine. If a pregnant woman is found to be non-immune, she should be vaccinated after the pregnancy and avoid pregnancy for 28 days after the vaccination, again, because it is a live vaccine. Infants with congenital rubella syndrome should be tested with a culture testing for IgG or with PCR. If any of these tests are positive, consider the infant contagious with rubella until 1 year of age, unless 2 cultures 1 month apart are negative after 3 months of age. There is no defined treatment for rubella. The next disease is cytomegalovirus, also known as CMV. CMV is a type of herpes virus. It is slow-growing, will give a lifelong infection, and often presents acutely with nonspecific viral symptoms. It can be transmitted sexually, through breast milk, through close contact with oropharyngeal secretions, or through blood transfusions. Young children that have CMV often shed the virus when they have high titers. So women that are pregnant that are exposed to young children should be aware of their risk. The risk of symptomatic congenital CMV is highest when pregnant women acquire a primary infection during pregnancy. CMV is one of the major non-genetic causes of sensory hearing loss and neurodevelopmental delay. CMV, for most people, is a very mild illness. However, in periods of immune suppression or pregnancy, it can have devastating consequences. Congenital CMV presents with hepatosplenomegaly, jaundice, conjugated hyperbilirubinemia, thrombocytopenia, petechiae, which is a rash with pinpoint red or purplish spots, microcephaly, seizures, hypotonia, and also intracranial calcifications. What separates this from toxoplasma is that these calcifications are often periventricular versus spread out in the brain. CMV can also present with chorioretinitis, intraventricular hemorrhages, and periventricular leukomalacia. Neural stem cells are very susceptible to this virus, which also causes neuroinflammation, which you can see with the neurological sequelae. Placental insufficiency can also develop due to local infection with CMV in the placenta. This can lead to intrauterine growth restriction. To diagnose the mother, you will want to test for IgG or IgM antibodies to CMV. IgM can last up to 8 months, which can be confusing depending on when you test. To diagnose CMV in an infant, you can isolate the virus from saliva or urine specimens within 2 weeks of birth for viral culture. You will want to do this within 2 weeks because you cannot be sure if it was a maternal to child transmission. To monitor for congenital CMV, during pregnancy, head ultrasounds of the fetus can be done at regular intervals. Maternal infection is not diagnostic of fetal infection, and even a mother with low titers can still have a child with congenital CMV. Ganciclovir and valganciclovir are the 2 antivirals that are currently used for the treatment of symptomatic CMV-infected infants. Infants diagnosed with congenital CMV should continue to have close follow-up with developmental, hearing, and ophthalmologic assessments. The next organism, HIV, starts the last letter of our acronym. HIV is a retrovirus that affects dendritic cells, lymphoid tissue, and causes CD4 cell depletion. HIV can progress to AIDS. HIV is spread through blood, semen, pre-seminal fluids, rectal fluids, vaginal fluids, and breast milk. Maternal viral load, CD4 count, the stage of the disease, breastfeeding, and active infection all affect the risk of transmission. The table on your right has a nice setup of the timing of transmission, the rate of transmission, the mechanism, and how to prevent transmission. The 3 main modes of transmission are in utero, intrapartum, or through breastfeeding. To test and treat for congenital HIV, you will want to test the mother early in pregnancy, again in the 3rd trimester, and at the time of delivery. You will also want to test postpartum, as she may choose to breastfeed. There are usually no clinical signs of HIV infection at birth. You will want to test HIV-exposed infants within 48 hours of birth, at 2 weeks, at 4 to 6 weeks, and at 4 months, with PCR or qualitative RNA testing. Early combined antiretroviral therapy for infected infants reduces mortality and increases attainment of normal developmental milestones and gross motor skills. If untreated, the infant often presents with recurrent infections and chronic diarrhea. The next organism is herpes simplex. Herpes simplex virus has 2 types. HSV-1 is more commonly seen to cause infections around the mouth, so this is your common cold sore, and HSV-2 most commonly causes genital infections. Similar pathophysiology is seen in HSV as the other herpes viruses. Mothers should be screened during prenatal visits, and a history of HSV should be documented, as herpes is a lifelong infection and cannot be cured. Neonatal herpes simplex infection is most often acquired in the peripartum period from maternal viremia, so an active infection, an ascending transplacental infection, which is from the outside in through the placenta, or retrograde spread through intact or ruptured amniotic membranes. Intrauterine transmission of HSV is rare. About less than 1/3 of infants with congenital HSV exhibit the characteristic triad, which is skin vesicles, eye damage, and central nervous system manifestations. The central nervous system manifestations have the highest morbidity. The SEM manifestation, or skin, eye, and mucocutaneous, is the most commonly seen and does not have high mortality. However, SEM herpes can progress to disseminated herpes, which can also affect the liver, and this does have a high mortality. Infants can also present with placental infarcts, hydrops fetalis, or even in utero demise. A picture of the skin lesions of a newborn with HSV is seen on the right. To test and treat for herpes simplex, you can test the mother if there are active lesions, or you can test for titers during pregnancy. With someone with recurrent genital herpes, so they continue to have lesions, you will want to provide the mother with suppressive therapy at 36 weeks. If there are active lesions at labor, a C-section should be used as a delivery method to decrease the risk of transmission. Infants are often asymptomatic at birth. If a newborn has vesicular lesions, evaluate for HSV with PCR. HSV can cause meningitis and encephalitis, so watch for any neuro changes in the infant as well as any skin changes. Newborns can be treated with IV acyclovir, which is the antiviral of choice for herpes simplex. Hepatitis B is the next H. Hepatitis B virus is double-stranded circular DNA that's enveloped. It causes cellular injury from host immune response, which is cytotoxic to hepatocytes, via cytotoxic T-cell activation. Transmission is most often at the time of delivery, with mothers with an active infection, usually later in pregnancy. We need to talk about the different components of hepatitis B virus. For our purposes, you just need to know that there are antigens in the envelope, the core, and on the surface. So the maternal envelope antigen, which can be seen in active infection, is small enough to pass through the placenta. For someone who is vaccinated, they will only have seen the surface antigen in the vaccine, so they will not have antibodies to the envelope. Perinatal infection has high chance of developing both acute and chronic hepatitis B in infants. You'll want to screen all mothers for hepatitis B using the HB surface antigen, and again at delivery. Again, this is the antigen, not the antibody. If the antigen for the surface protein is positive, newborns should receive prophylactic hepatitis B immunoglobulin at delivery, as well as the hepatitis B vaccine within 12 hours. And completion of the series by 6 months with follow-up testing. This is only prophylactic. We do not have a confirmation of hepatitis B transmission. To confirm, you will want to test newborns for hepatitis B antigen within 1 to 2 months. The next virus is hepatitis C. Hepatitis C is a single-stranded RNA that infects hepatocytes, but it may not be directly toxic. Hepatitis C is the number 1 cause of chronic liver disease in the world. Transmission occurs through pre- or perinatal exposure to peripheral mononuclear cells infected with hepatitis C in pregnancy. In general, it can be transmitted through blood. Other factors that increase the risk of maternal to child transmission are HLA types, female gender of the fetus, and an HIV co-infection in the mother. The method of delivery and choosing to breastfeed are not associated with maternal to child transmission as some of the other diseases have. Most infants are asymptomatic but may develop chronic hepatitis C. There is no proven transmission prevention method. However, if it is known that the mother has hepatitis C, invasive instrumentation or prolonged rupture of membranes during labor should be avoided. If you're concerned about transmission to a newborn, you should test with RNA PCR after 1 to 2 months of life. Anti-HCV IgG should be tested after 18 months of age, and if positive, you should repeat testing after 12 months, as the infant may have cleared the infection on their own. Interferon-based therapy, ribavirin, New antivirals for hepatitis C and IVIG are all commonly used to treat adults with hepatitis C. However, these are not indicated in infants. We have now covered all of the organisms that in torch infections. The last slide has a nice table with takeaways of the most common findings in each infection. As you can see, many of these infections have similar sequelae. The way that you'll remember them are by the specific unique sequelae that usually occurs with that infection. For example, toxoplasmosis is the only disease in this chart that presents with diffuse intracranial calcifications. And again, toxoplasmosis causes local calcifications due to tissue necrosis, so this would make sense. Treponema pallidum can present with a rash. It can also have chorioretinitis and glaucoma, which is different. You will also see the infant with snuffles or Hutchinson teeth can be mentioned in a question stem. Rubella, the most common sequelae that you will see on tests is a patent ductus arteriosus, as well as pulmonary artery stenosis and myocarditis. You'll also see cataracts and microphthalmia as indicative of rubella infection. The blueberry muffin rash is not specific to rubella, so you should not rely on that for the diagnosis. CMV can cause deafness as well as rubella, but it can also present with calcifications in the brain. To separate this from toxoplasmosis, you have to remember that these calcifications are periventricular, meaning you'll see small white spots studding the borders of the ventricles. For HSV, which is herpes simplex, you will often see a vesicular rash on the newborn. And if not, you can see myocarditis and ophthalmic manifestations such as cataracts and chorioretinitis. Finally, for parvovirus B19, hydrops fetalis is the buzzword that is often associated. You will want to look for maternal risk factors as well as maternal infection, as well as the congenital syndrome, which can have subcutaneous edema, myocarditis, and ophthalmologic abnormalities. Thank you for listening to this lecture about torch infections, and I hope you feel more comfortable in identifying a variety of diseases that can be transferred from mother to child.